Hello, everyone. Welcome to Infection Part 3, the problems. I'm sorry. Anyway, hi, it's Ms. Rader again. We're going to finish up our discussion on infection today, starting with the problems of inadequate antimicrobial therapy. Sometimes the reasons that patients have problems with their antimicrobial therapy is lack of funding or lack of knowledge. Noncompliance and non-adherence to an antibiotic regimen can be because, they get to feeling better. Maybe they have a cellulitis on their leg and it's looking really a lot better. So they don't take their medication and they save it for another, infection instead of completing the course. Or maybe they were given a prescription at the hospital and they discovered that it costs, you know, $200 to fill and they can't afford it. So that's where patient education and coordination comes into play. Now, some infections, for example, TB clinics, have legal sanctions compelling a patient for treatment. So if it's found that a patient is not taking their medication, um, most TB clinics today, or the one that I'm familiar with, they no longer have where they come in every day for their medication. Most of the time, it's follow-up phone calls and tracking. One of the big problems that we need to educate our patients about when they are not compliant with their antimicrobial therapy is that it can lead to, that small amount of cellulitis, say on their leg, the localized infection can become systemic. And with the systemic infection can become septic. And then sepsis can lead to shock and death. In fact, sepsis is the number one cause of death of hospitalized patients stemming from infections. Interprofessional collaborative, why is that up? Sorry, guys, I just realized I didn't have it on full screen. I'm sorry. I'm not going back and redoing it. Anyway, interprofessional collaborative care assessment. We as nurses are excellent history takers. We're good at getting the information from our patients. When you're looking at history, you want to look at their pre-existing disease processes. You also want to look at recent hospitalizations. And remember, just because they haven't been to the hospital where you are doesn't mean they haven't been treated somewhere else, perhaps at an urgent care or their physician's office. A lot of times when we ask a hospitalized patient, when was the last time you were admitted, they fail to mention the last time they were at the urgent care or the emergency department and were sent home. We also need to make sure that we do a physical assessment on that patient to look for other bumps and scrapes. And sometimes it's interesting, especially when dealing with some types of infections like cellulitis and things. You see this huge scar on their leg and you go, what happened? And they go, oh, that's where I had cellulitis, 3 years ago. And you're like, you said you didn't have it before. Oh, yeah, I forgot about that. Well, that one went away. So when you're doing your physical assessment, it's also a good time to find out other things about the patient. It's a great time to have a small conversation. It's interesting what information you can get when you're not just asking regimented questions off of a paper. Psychosocial assessment, looking at their feelings towards the infection and towards how they're feeling about getting better. I find this a lot, especially with patients who have a history of MRSA and are placed on isolation precautions until their lab results come back. They feel isolated. They feel sometimes they'll feel like have the mark because there's signs on their door. And I'm also seeing this with our COVID patients, where because here they're placed on special cohort units, the staff come in looking like some kind of wildebeest from outer space with all of our plastic gear on, and it's very isolating. And because we can't spend a whole lot of time in the rooms with them, um, I've had women who are actually, she was a nurse by profession. She said, I know as a professional that I am not being isolated or outcast, but it's hard not to feel that way when my providers and my caregivers are not wanting to spend extra time in the room with me. And that it's a very lonely, very isolating um, time. And I think we just need to be aware of that. In fact, I found myself when taking care of COVID patients, especially, you have to understand, I work with mostly very alert, very oriented patients who are not allowed visitors. And even though I didn't spend extra time in the room with them for safety, when I would call to see what they needed me to bring into the room when I was coming, I would chit chat on the phone with them for a few minutes. Is there anything we can get for you? Is there something you want us, or one lady, she was really wanting just a hospital gown, or a gown other than her hospital gown. And I said, well, why don't you call one of your family members? And if they bring it to the main gate, we'll go out and get it. And little things like that can make a huge difference in someone's psyche when they're in the hospital with an infectious disease. Laboratory assessment. Best procedure for identifying microbes is a culture. And then after you've heard of when that we gather a CNS urine on a patient, or you may hear that we're doing blood cultures. What we're actually doing is a blood culture and a sensitivity. The culture is the best procedure for identifying the microorganism. And then what the sensitivity testing does is it determines what drugs have the best effect on certain organisms. We also look at white blood cell counts. For most active infections, especially bacterial, the total leukocyte count will be elevated. When the diphthesyl count elevates, the number of immature neutrophils will shift to the left. See, that's because you see an increase in the neutrophils. And we remember that the neutrophils are the immature leukocytes. It's basically because we're making more. Now, sometimes when people are not able to produce neutrophils, they become neutropenic. And you will see neutropenia in mono, and you'll also see it in malaria. The SED rate, or the erythrocyte segment rate, you'll hear it in the hospital. They'll talk about the SEG rate being elevated, but that's the erythrocyte segmentation rate. Sorry, not re-recording it. So let me start over. The erythrocyte segmentation rate you will hear in the hospital called the SEG rate. And what that looks at is the rate at which red blood cells fall through the plasma. And this rate increases the number of acute reactants during the inflammation phase. So increased SEG rate shows inflammation. And remember, we talked about sometimes inflammation, not always, but sometimes inflammation occurs with infection. So an increased SEG rate means that there is some type of inflammation or an infection in the body. Now, a chronically elevated SEG rate can be a sign, and you will see it in chronic infections such as osteomyelitis, or if someone has a history of chronic abscesses, they have community-acquired MRSA, and they've colonized, and sometimes they will have boils or abscesses pop up. They'll have chronically elevated SED rate. You also see it though with other, because remember we were talking about that SED rates are seen in patients who have inflammation. You also see it in diseases that cause chronic inflammation, such as inflammatory arthritis. So you need to know that's, again, a reason we need to make sure we get a thorough history on a patient, because we don't want to see an elevated SED rate and then they go, oh yeah, I have really bad arthritis in my knees. Look how swollen they are today. And they're there for an infection in their big toe. Serologic testing is performed to identify pathogens by detecting the antibodies in the plasma. Now, you see an increase in the titers during the acute phase of an infection, but then you'll see it start to taper down. Um, you'll see it start to taper down as they leave the acute phase. Serologic testing is also how they do titers on, on like like our hepatitis B vaccines. I got my series of the 3 vaccines, way back in the 90s. Well, when I was going grade to go back to graduate school, they needed to do a titer. And people smarter than myself determine what a good titer is by doing a serological test to see what the number of your antibodies needs to be in order to be considered vaccinated from that our vaccine still being good or not needing a booster. So that's another reason that we use serological testing. Imaging testing or x-rays, CT scans, you sometimes could do that to see has there been damage from the or damage or scar tissue from infections, such as from in the TB in the lungs, or if you can also look at inflammation, and with ultrasounding you can look at how far back an abscess goes. You may be able to feel the ridges, but a CT scan can sometimes show you like the pocket of fluid or pus that gives the physician a better idea on whether or not surgery is needed in order to get rid of the infection.